Wound healing. Wound is defined as a disruption of the normal structure of the skin layers and or underlying tissues caused by application of force. Wounds can be classified into simple versus complex, tidy versus untidy, closed versus open. But surgical wounds are classified into clean, clean contaminated, contaminated, and dirty. Types of wound according to closed and open wounds. We will start by closed wounds. Number 1. Abrasions. The partial denusion of the superficial layers of the skin due to friction with rough surface, resulting in painful raw area, can be treated by dressing and antibiotic. Contusions. Blood extravasation with plasma exudation due to damaged small blood vessels, resulting in painful, swollen, and ecchymotic skin, can be treated by fomentation, cold at first and then hot, elevation and compression. Number 3. Hematoma. It's blood extravasation within the facial planes due to rupture of sizable blood vessels, resulting in painful, fluctuating swelling, can be treated by fomentation. We start by cold fomentation, then hot, elevation, compression, antibiotics, and aspiration. Open wounds can be classified into incised wound and lacerated wound. We can compare them according to the cause, damage, ages, bleeding, infection. Incised wounds are caused by sharp instruments with minimal damage, with clean cut edges, with severe bleeding, and little incidence to infection. But the lacerated wound is caused by blunt instrument with severe damage and crushed edges, with minimal bleeding and more liable to infection. Some pictures comparing between incised wound and lacerated wounds. Number 3 in open wounds is crushed wounds. They are more extensive type of lacerated wound as road traffic accidents wound, war injuries, industrial injuries. Number 4. Penetrating wounds. Perforating wound has an inlet and an outlet, but punctured wound has an inlet but no outlet. Wound healing by primary intention occurs in clean, incised or surgical wounds. All layers are closed. Healing process is uncomplicated. There is more epithelial regeneration than fibrosis. The incision heals rapidly and with minimal scar formation. Healing by secondary intention occurs in wounds with extensive tissue loss, as wounds with sepsis, excessive trauma, burn, or imprecise approximation of tissue. Deep layers here are closed, but the superficial layers are left to heal from the inside to out. Healing by tertiary intention. It's also referred to as a delayed form of primary closure, left open initially from the start. After wound debridement and control of infection, wound here is closed by sutures or skin graft finally. Treatment of wounds. We should start as first aid by airway, protecting airway and prevent anoxia, prone position, airway insertion, suck any secretion and insert into tracheal tube. Breathing. Prevent pneumothorax, treat flail chest. Circulation. Insertion of venous line, manage shock and hemorrhage. Disability, rigid cervical collar, splint fracture, dressing for any open wound. Exposure of all parts of the patient to exclude any associated injuries. Surgical treatment, through cleaning of the wound with saline, removal of any foreign bodies, wound sterilization and antiseptic solution. Definitive treatment of the wound within the first 6 hours in a clean wound by primary repair. Lacerated wound should be managed by wound excision, skin, fascia, muscle, neurovascular bundle, foreign body, bone, and then primary repair. Crushed wounds should be managed by wound excision and delayed primary repair. From 6 to 24 hours, clean wounds are managed by delayed primary repair, but lacerated and crushed wounds are managed by wound excision and delayed primary repair. After 24 hours, any wound should be managed by debridement and systemic antibiotics, then delayed primary healing. For hand and foot injuries, either amputation or microsurgery implantation may be needed, as in these pictures. Complications of the wound. General complication as shock, neurogenic shock due to pain, hypovolemic shock due to fluid loss, septic shock due to late tissue necrosis and infection. Crush syndrome. It is due to massive muscle crushing, causing blood extravasation, muscle swelling, increased tension inside the fascial compartments, increased tension over the blood vessels, causing ischemic damage of the limbs. Myoglobinuria, causing acute tubular necrosis and acute renal failure. It's managed by sodium bicarbonate to correct acidosis, intravenous mannitol solution for hypovolemia, fasciotomy to manage intracompartmental pressure. Neglected cases should be managed by dialysis, and amputation is life-saving. Local complications. Infection, biogenic or gangrene. Gangrene, infective or ischemic. Injury to deep structures as brain, heart, and other systems. Formation of scars. It's an area of fibrous tissue that replaces the normal skin after an injury. Phases of wound healing. 3 phases: inflammatory, proliferative, and remodeling phase. Inflammatory phase, hemostasis and inflammation. It lasts for 4 to 6 days. Features of inflammation are present. Exposed collagen activates the clotting cascade. Inflammatory cells add monocyte, macrophages, and granulocytosis. Table showing summary of the inflammatory cytokines in the inflammatory stage. Proliferative phase. Here is the epithelialization, angiogenesis, and provisional matrix formation. It begins in the 7th day and lasts for 6 weeks. Production of collagen is the hallmark here. Remodeling or maturation phase. It is the maturation of the collagen by cross-linking random to organized fibers. It begins at 6th week and lasts for 2 years. Wound may increase in strength for up to 2 years after injury. Impaired wound healing is due to infection, ischemia, edema, elevated tissue pressure, and for here is the factors affecting wound healing. there are local factors as surgical wound handling, infection, tension closure, shearing forces, ischemia, denervation, presence of any foreign bodies. General factors in the patient as drugs, smoking, nutritional deficiency, systemic diseases, age, and irradiation. Scar. Ideal scar is thin and flat. It has a good color matching with surrounding skin. It's also oriented along the relaxed skin tension lines. It does not produce any distortion of the adjacent tissues. Lines of Langer. It is the lines of the least skin tension. Lines of Langer generally run parallel to the natural skin folds or perpendicular to the underlying muscle fibers. For examples, horizontal in the forehead and circumferential in forearm or leg, as shown in this picture. Scar classification. Mature and immature scar. Mature scar is a light-colored flat scar. Immature scar is a red, sometimes itchy or painful, and slightly elevated scar. In the process of remodeling, many of these scars would mature normally over time. Linear hypertrophic scar. It's a red, raised, sometimes itchy scar confined to the border of the original incision. Increase in size rapidly for 3 to 6 months and then begin to regress. After maturation, they may have an elevated, slight rope-like appearance with increased width. Widespread hypertrophic scar due to burn, as example, it's a widespread red raised, sometimes itchy scar that remained within the borders of the original injury. Minor keloid. It's a focal raised itchy scar extending over normal tissue. This may develop up to 1 year after injury and does not regress to its own. Major keloid scar. It is a large, raised, more than half centimeter scar, possibly painful or pruritic and extending over the normal tissue. This may result from minor trauma and can continue to spread over years. In addition to above-mentioned varieties, scars may be atrophic, depressed, hypopigmented, hyperpigmented, or irregular with nodularity. Here is a difference between hypertrophic scar and keloid according to its incidence, extent, result, and recurrence. About hypertrophic scar, its incidence is healing more than 21 days, confined to the site of the injury, and resolution over months, rare after proper excision. About the recurrence. Keloid, its incidence, more in young, more in negroes, more in female with genetic disturbance. It extends to the surrounding tissue and never improves. It's large or persists with high incidence of recurrence. Prevention. Early release of tension by grafting or local flaps. Tension in a scar encourage hypertrophy. Continuous scar massage after application of skin emollient. Pressure on mature scar tissue by compressive garment for 24 hours per day for at least 6 to 12 months. Treatment. Release of tension. Intralesional steroid injection as it inhibits fibroblast growth and breakdown collagen deposit. Application of silicone gel sheet as an occlusive dressing. Ideally, it should be placed 24 hours per day for about 1 year. Occlusion appears to increase the temperature of the scar, possibly increasing the collagenase activity. Hydration causes softening of the scar. Cryosurgery. It uses liquid nitrogen to cause cell damage and to affect microvasculature with subsequent stasis, thrombosis, and transudation of the fluid resulting in cell anoxia. Laser therapy. pulse-dyed laser, microvascular thrombosis, carbon dioxide laser and argon laser causing collagen shrinkage through heating. YAG laser inhibit collagen metabolism and production. Interferon therapy by intralesional injection of interferon alpha, beta, and gamma. Its mechanism by reduce fibroblast synthesis, reduce collagen type 1, 3, and 4, increase the collagenase activity. Some pictures showing pressure treatment. Some picture also showing pressure treatment. Effect of the pressure treatment: accelerate scar maturation and flatten of the scar, increase pliability, decrease blood flow, realign collagen bundles, decrease edema, decrease the rate of collagen synthesis or lysis. Some examples of silicone gel. Picture showing keloid scar. Another picture showing keloid scar. Keloid scar. Keloid scar also. Thank you.